for effective treatment of sleep apnea. And as I normally do, I alter it a little bit as I go along, because as I was putting it together, while that's a critically important piece, the technology helps us not just for sleep apnea, but for everything we do. So as we go through, I'll show you some of the things that I've adopted and why I've adopted them and how they've changed things. One of the big changes I had to make in my own life, and that you're going to have to make in your life, is deciding who you are and what are you going to do? What's your profession? Because all of us are orthodontists, and orthodontists typically think that's straight teeth. That's what it means, is straight teeth. And if you look at our journal, it expands it to a dental facial orthopedist, which means you're going to change the bones, and we can do that. We know how to do that in many, many ways. The question is, can we do more than that? And as a speaker on sleep apnea and as a seeker in sleep apnea, I think we can have the biggest change of any other dental specialty, certainly, and working with other medical professionals, we can have a huge, huge impact on people that have this disease. So I think we can do more. And I think we should do more. We have opportunities to do more, and we really should. When you think about technology, it allows you to do a more comprehensive diagnosis. That's the first big thing. And the more you can see, the more opportunities you have for fixing the things that you see. But there are things that you can't fix if you don't even know they're there. So it allows you that. It allows you to get better, faster results, and it allows you to do better treatment. So you can, and all these things have happened. I started with lasers, and I wasn't even seeing some things that I could fix. Once I realized I could fix them, that became part of my diagnosis. So this goes back and forth. Once you have a solution here, then you have a more comprehensive diagnosis to add that to the diagnosis. So when you think about OSA, really, there's certain things we can do. We can screen patients for OSA. And how many of you have been treated or doing an exam on one child, and the brother is winding around and crawling under the table and whipping around and touching his brother and doing all kinds of things? All those are symptoms of an airway problem. All of them are. And so if you start to recognize what those are, we can screen them. We can screen, and once you start talking about sleep apnea in your exam, now all of a sudden, well, wait, my husband snores. Is that sleep apnea? It's on the continuum, so let's look at that. Or my uncle or my other kid. You start to see things you do and the patients around you do, and then they tell other patients. So it starts to become an exponential change. We can obtain a diagnosis, so we can test. We can do some things in our office, but at the end of the day, it's a medical diagnosis. So I don't diagnose sleep apnea, not ever. However, I work with a sleep doc who does. I work with a number of other professionals that work on different parts of it. I work with the ENTs, with the sleep docs in the area, the hospitals, all kinds of people. So we can help obtain a diagnosis, but the biggest thing we can do is screen, and we can treat. Because we are the architects of the mouth. We can change things in the mouth that are in ways that make it better, better for people when they're trying to breathe. So the first little piece of technology I would recommend you start using, and start using it immediately, is this questionnaire. So Chervin and his group at University of Michigan put together this questionnaire that you give to kids. It's all this is for kids. The adults is a different questionnaire. But start screening every one of them. And I took all their questions, put it on my letterhead. If you want a copy, just let us know at HSO, and we'll make sure you get a copy. And have mom fill it out. Does the kid snore? Are they having trouble managing themselves? Do they get in trouble at school? Those sorts of questions. That's the first step. Every single patient. And we go over this in the 2-day course that I give, to go through step by step. Now, when you go to your clinical exam, when you look at the health history. There are things that you'll see in the health history that might direct you toward this might be an airway problem. There are things you might see in the clinical exam. There's really not time to go through that now, but there are a ton of things you can do. And one of them, and I highly recommend, is that you go to 3D x-rays, because you can see things that you can't see otherwise. This is Poiseuille's law. I had to actually memorize how to say that. And what it says is that the resistance, now that doesn't show up, the resistance to flow, it varies by the fourth power of the radius. Well, generally speaking, I'm not measuring the diameter of the airway. I'm measuring the minimal cross-sectional area. I want to know, just like if you have a hose and you bend it in half, it stops flowing. Air is the same way. If you have a small area, that's what's going to determine the flow. And if you can widen that small area, well, then you get better flow. So I just altered it to the area. So the resistance varies with the inverse of the area squared. If you double the airway, you've got 4 times the airflow. A little bit goes a long way. And so people that are suffering from sleep apnea are having obstructions where they stop breathing. That's what we're trying to do. So we're looking for the minimal cross-sectional area, want to measure it, and know that every increase we can do is going to help them with their airflow. And there's a lot of ways to measure airways. This is the old-fashioned way. I don't recommend doing that. Not everybody can tolerate that. This is the newer way. We were using 2D to look at them and say, oh, look, the airway looks fine. And it does when you overlay the whole of the head. But when you look at it from a different direction, you start to see that there's a problem here. And there's a tonsil that's holding that over. And that's minimizing the airway. That's where the problem is. Okay? And so one of the things that we're going to get from 3D CBCT is the ability to identify where the problem is and direct our treatment to the problem, not just throw CPAP at it or throw oral appliance at it. It's not a knee-jerk reaction or a one-step-fits-all. Figure out where the problem is and identify it, and then find the solution that fits that. At this point, we have some data, okay? We know that the minimal cross-sectional area for most adults, males and females, are, for males, 172 millimeters squared, for females, 150 millimeters squared. We have another study, Lowe and his group, where they just divided it. Said if it's above 110, that's a mild risk. If it's above 150, it's normal. But if it's above 110, mild, moderate if it's 50 to 100, and high risk 0 to 50. Okay? You have to take some of that with a grain of salt. So I apologize for my clicker. So Mariana Evans took 3 different ICATs on herself. One when she was breathing in, one when she was breathing out, and one when she swallowed. So there's a high variability between these. So all the studies we have to date, I don't think have controlled for that. Not all the studies, all but one that I know of, haven't controlled for that. So we have some noisy data, okay? However, there is one study that did control for it, and they had a very specific protocol for how they took them and when they took them and what they were looking for. So they had the patients breathe out completely, well, swallow, breathe out completely, and then hold their breath, okay? And so now you're going to get the minimal cross-sectional area that they can get because they've breathed out where there's still a patent airway. And if we do that consistently, we should have better data as we go forward. So I would standardize them. I'm going to try and have the world standardize them so that we have data that we can use. Shandell and his group looked at a whole bunch of people, 1,300 people over all ages, and measured the minimal cross-sectional area and then said, all right, here's what they are. And if you look, from 6 to 8, it's 77, and from 9 to 11, it's 89. And what they said is, well, yeah, it's about 10 times the age. The problem is, when you look, it's 10 times the age, but the standard deviation is so high then it's hard to hang your hat on that number. That means that when you're 6 to 8, you're somewhere between, what is that, 29 and 125. Okay, the range is so high that it's not really meaningful data. But if you if you map the data, you see that it's a pretty good straight line fit up to age 20, and it gets bigger up to age 20. After age 20, it starts getting smaller, and after age 50, it gets smaller faster. Okay, so know that one of our goals would be to make the airway as big as we can before age 20. We don't want to minimize it. Now, I'm not an all or nothing guy. I never will be. But I know that's a goal. I'm going to try and make the airway as big as possible by age 20. That we do know. So when you look in at this young man, you don't know the history on him, but when you look in, do you look at him and say, we need to do something to fix the crossbite? Most orthodontists wouldn't. And so if you're looking and you're saying, I'm an orthodontist, I'm going to look at teeth, and you look at the teeth, there's no crossbite there. I don't look at that anymore. That's not how I determine it. If you look just at the teeth, you'll get they all look about the same. But they're not about the same. This is the normals, where the teeth are upright and biting straight down on each other. At the far end, both of them are tipped in. In the middle are all variations on a theme where they're tipped in on the bottom and tipped out on the top. And so what they did is they said, well, the normals, it's about a millimeter difference between the maxilla and the mandible. And when you look at the group at the far end, it's in the same order. The maxilla, the bone itself, is approximately the same size. And if you look, that's about 50% of the population. But if you look at all the middles, those are all the same, in the same range. So all the people with a unilateral crossbite or a bilateral crossbite, or the lower teeth tipped in, the upper teeth tipped out, all of them have maxillary deficiency. So when I'm trying to decide whether or not I do an expander, that's what I use. Okay? Not just look in the mouth. I look in the mouth too, but this is where I look at it and say, all right, is it in fact? And I can measure it if I want to in real time. There's no expansion on 3B-CDCD. There. So we want to look, this was their conclusion, and I agree with it, is that sometimes when you look in the mouth and there's no crossbite, there's still a problem with discrepancy between the jaws. Point of view matters. If you see this, Prince William is probably doing something he shouldn't do. And this is no doubt what showed up in all the tabloids, right? However, there's a very different picture if you look from a different direction. And you can't always determine the direction when you're just taking maybe an AP ceph and a lateral ceph. You might miss something. So here's a young lady with impacted cuspids on one side. Where are they? Where are they relative to other things? You really don't know. You still don't know. I would suggest that this is the way that you know. If you can do these kinds of manipulations and look that close and twist it and see, that's where you really find out what's going on. Because if you just see two static images, you might miss something. And so do you want to guess as you're deciding things? Do you want to guess which direction you're going to pull that? Do you want to pull it against the bicuspid on the buccal? Or do you want to pull it maybe on a pad in the roof of the mouth to get it away from the lateral before you bring it into the arch? That's one of the benefits of CBCT. This is my niece. And I don't do this on every patient, but I can give you an idea of what I'm talking about when I'm looking at the angles of the teeth and how you would plan treatment. This is the sort of thing you can do. This is an Anatom model that you order from Anatomage after the fact. And they take your 3D CBCT and they put the teeth on it, and then you can manipulate it. Okay? It's a minute or so, so bear with me. When they get to the part where they do the treatment plan, it's stunning. And I would suggest it's way beyond anything I've ever done other than just sort of a ballpark idea in my head. You can look and see exactly where things are without any expansion. Right? There's no 7% expansion because the film is far away from the head. All right, so now we're going to treat. Oh, we're going to show the airway first, which is a really tremendously valuable thing. Again, if you standardize it, it's really, really great. You can see her tonsils are enormous. Bless his heart, J.C. Quintero was kind enough to see her. They live out in wine country. Her mom is the winemaker for cake bread, so they live out in wine country, and he was able to see her and develop a treatment plan, but then somebody else did the treatment for her. All right. So they've sectioned the upper jaw, right? And now this is the treatment plan. We're going to upright the lower molars, and we're going to do an expander, and that's going to give us room for those cuspids to come in. Notice where they are right now, and notice what happens when it widens. All of a sudden, there's room for those cuspids to come in. This is a whole different level of treatment plan, and you can't do this with a pan and a ceph. You really can't do it with models very practically. But once you have an anatomy model, you can do it. So if you have a tougher case, I don't do this routinely. I know Sean does. But if you have a tougher case, this is a great way to see, all right, what am I going to do? And how much expansion do I need? Where do I want to go with this? That's one of the benefits of CBCT. And probably the biggest one, the one that's going to really change the industry, is that we can superimpose now. And so Sean's group with OrthoScience, the goal is for people to get before and after CBCTs and compare what actually happened. And you can, it's not just that you're superimposing them. You're superimposing on cranial base, on the air cells, on the bony pieces in the anterior cranial base, and you're getting a true superimposition. And then you can look afterwards and say, what actually happened with this treatment? You can see the jaws themselves are different, but it's matching up there. And we're doing this routinely for before and after, and there's probably 20 or 25 of us doing the same thing. Not the same thing. We're doing our own thing, but sending the same data into this database. It's going to be able to be mined to be able to say, you know what, when this happens, this is what happens. When they do this treatment plan, this is what happens. And it doesn't matter if I do it, or Sean does it, or somebody else does it. This is what happens. Or whenever Lou does it, it does this, but whenever Sean does it, it does that. We'll know these answers. And this is the kind of image you get where you can see what actually happened. That's probably the biggest thing we're going to get out of that. So just to give you an idea, and sometimes technology doesn't have to be something special that plugs into the wall. This is a young lady who I treated. This was my first one. And in the past, when I had this problem, I had two choices. Either I would try and protract 4 to 4, put power chains on and hope that the molars were strong enough to push everything forward, or do some sort of expander and a face mask. Those were my choices. And this was my first chance that I do this with every patient, so I just threw it in there to show you. There was her airway, 76, which is a little small, but she's not full grown. And it's small at the mandible. And there's the angulation of the teeth. And so I put in an RPE, and this was my first class 3 Carrier, which I used, and I didn't read the directions as well as I should. And 2 months later, she's in Force 2 elastics, and all of a sudden, those teeth are really mobile, and I'm pretty nervous, and I'm saying, yeah, maybe you shouldn't wear them. She should never have gotten off Force 1s. It was my mistake. Okay? But that's where we were, and I'm wondering, are we going to be okay? I got nervous enough that I didn't go further. I should have gone a little bit more class 2 almost. That's 9 times the airway, 9 times the airflow. And this is what happened. Okay, and I don't have to wonder. I know what happened. She got a little bit of tipping down in the mandible, so we got some occlusal plane change. The maxilla had an orthopedic effect and brought it forward. I didn't expect that. I really didn't expect an orthopedic effect from a Carrier, but that's what we're finding over and over and over and over. So that's where she is. That's 6 months later. From where she was to where she is, for me, was a miracle. Now, again, I should have gone a little bit past class 1 because she's relapsed. She's now biting pretty much end to end. And just April 20th, I put her in some CS 2000s to get back some of what we lost. But that was me on technique. Okay? Here's Chris. In Chris's class 2, I a class 2 Carrier, when the cuspids are up a little bit, because one of the side effects is it brings them down, and if I know that that's the side effect, I try and take advantage of it. So that's what I did. Really, the molars are pretty well upright. I'm not thinking expander. This thing's driving me crazy. There we go. So we did a class 2 Carrier, and that was the result. We got 4 times the airway because we got an orthopedic effect. I didn't expect it. But when you superimpose, you get an idea of what happened. And why it's more on the left than the right, I have no clue. Okay, I haven't got that figured out yet. But I know that's what it is because we can superimpose so precisely. So in my mind, getting a CBCT is a no-brainer. Okay, I know they're expensive. I get that part. But you get so much information and so many things that you can look at, and it makes you such a better orthodontist that is, just do that. That's get it done. Other things, not necessarily so. I personally do a lot of stuff in sleep apnea, and I've been through a number of polysomnograms, and I know how intrusive that is into my life. So I've got a home sleep test. I've got 4 of them, okay? This one is the Knox on the bottom there. Fits on your wrist. It has a nasal cannula. Has a couple effort belts. It's not that intrusive, and the beauty is it's FDA approved for kids. So they can take it home. Imagine if you're going for a PSG, you got to go with them and sleep in the chair while they're getting their polysomnogram. If you do this, they can do it at home. And that's why, is because we've got, one of the things we can do, we have tons of solutions for sleep apnea, but one is to make these appliances. And when you make them, you want to make sure they're working. And ultimately, they're going to go back and get a PSG. But a PSG is an overnight sleep study. If you do that, it's like $5,000 a piece. You're not just going to send them every other week to see if you're there. So we advance this thing until the patient feels comfortable, until they say they're doing well, and then we'll do a home sleep test. And now you're talking about in disposables about $5 to do that. And you get an answer for where you think you are. Ultimately, they'll go back to the doc. Remember, it's a medical diagnosis. But we can do so many cool things to help them. So yeah, I would get a home sleep test. This is the sort of readout you get. How much time he spent sleeping, how much was in REM. His RDI is 33, his AHI is 33.7. That's high. That's severe apnea. And afterwards, his AHI was 0.9. Anything less than 5 is normal for adults. That was just with an oral appliance. And we can make those. And we can manage the consequences of making them badly. How many times have you gotten a patient who is their sleep apnea is solved and they're a massive class 3 and the dentist sends them to you and says, look, will you fix this for me? We manage it before it needs to be fixed. And there's ways to do that. Intraoral scanners. Just try. How many people have an intraoral scanner? Okay, so not everybody. All right. So I've got 2 Trios scanners. I bought them last year, okay? And then just before, like in September, I bought an iTero scanner for $30,000. And I wasn't going to buy another one at $15,000 just because they decided not to do the Trios. I want to be able to use my Trios, okay? And I can use it in 100 different ways. And so it's changed all kinds of workflows in our office. We also invested in some 3D printing. So a lot of this stuff we can do in office. So retainers. Used to be that what we would do is we'd schedule a 60-minute appointment. They'd come in, we'd remove the braces, remove the cement, do any Hollywood treatment. That's what I call when we recontour the anteriors. Take an impression, pour it up, then wait. Wait for it to come to, make the retainers, do the right away. And so now I've got an assistant gone, waiting for this thing to set up and to make the retainers, and then we would deliver. And it took forever, and they were sitting in the chair, kind of looking around like what's going on for a good portion of the middle of it. It was miserable. It was especially miserable when it didn't fit. Now what we do is before we take them off, we have them in and we scan them. So we do all the first stuff, remove the wires, do the Hollywood treatment, but then we scan them and get a virtual model. And my team goes in and removes the brackets virtually, prints the models, makes the retainers, and when we come in for the D-band, we just take off the brackets, clean up the cement, and give them the retainers and send them on their way. And they always fit. Okay, a scan is much more precise than any impression you'll take. So we're doing expanders, right? So the old way we would do a separator appointment. Usually that would be the first appointment, and if it was a same-day start, it was a separator appointment. I always felt bad about giving people credit for a same-day start when all they did was put in separators, but that's a whole other story. So separate, we have them back a week later. We would fit bands, take an impression, and send it off to the lab, have them make it, and then 2-3 weeks later we'd have them back, take out the separators, put in the expander. 3 appointments, 2 of them during the day. Okay, it was a morning appointment for most of those. Now what we do is if it's a same-day start, we'll go ahead and scan them and put in separators. So we reverse the order on that. From the scan, we can have it made and sent. So their second appointment is delivery, and it's just take out the separator and deliver it. And we do that now in the afternoon. Okay, it's now a 30-minute, 20-minute appointment that you can do as like another arch wire. And it becomes a same-day start pretty easily. Sleep appliances. So in sleep appliances, one of the things I do is I make a positioner. Right? If I take impressions, I got to take an impression of each arch. I got to take 2 of each arch, one for the positioner and one for the oral appliance, and then a bite. Now, a same-day start for me, they scan, my staff scans them. I come and do the construction bite, and we send the scan and the construction bite off, and we get both the positioner and the sleep appliance made from the same lab, and they send it to us. So the second one's delivered. These become same-day starts all the time, and if you know the stats from OrthoFi, if it's a same-day start, 100% of them start. If it's anything but that, it drops off. If they sign a contract, it's like 98%. If they don't, it's like 60%. I mean, it drops precipitously if you don't have a same-day start. So, clear aligners. We used to scan with the iTero and submit. We scanned with the Trios until that wasn't possible. Then, what we do now is we can scan with our Trios. I can run it through the clear aligners that we've developed here at HSO that are dead clear. You should look at them. They're just beautiful. And if you want to see it in person, there are people in the booth that have them on. But it's stupid simple on how we do it. We also do a lot of in-house aligners, and we're doing that with SureSmile software. So we do the setup. My staff does the setup in-house. Very little doctor time, and we get this done. I'm going to move a little bit quicker. So, soft tissue laser. Who wants to have a soft tissue laser Short lingual frenum is associated with obstructive sleep apnea. There's 3 studies, all recent, showing that. I have an intuitive sense that if you couldn't put your tongue in the roof of your mouth, it would probably have the same effect as if you didn't put your tongue in the floor of the mouth. So here's what it is. And when I do a laser course, these are the sort of videos we talk about. If we do it in office, we do it on a patient probably. But it's just this simple. You can do this in your office without bleeding. And suddenly they can come so 5-minute warning. This is the sort of thing. This has nothing to do with sleep apnea. It has everything to do with having a different result. Same teeth. I didn't move the teeth at this point. She was done. But this was the way she looked, and that's the way she looked after. And that's with a soft tissue laser. And we can teach you how to do all that stuff. It's, once you know the constraints. So here's where sort of a lot of this came together. This young lady is on Medicaid, and she decides she wants to have surgery to solve her sleep apnea. Okay? And she comes to me, and so I'm looking at it, and Dave Paquette turned me on to a possibility of something called surgery first, which made me nervous as could be, because that means my surgeon's got to put it somewhere where I can finish. And I'm looking at her saying, how am I going to keep the brackets on? Metal crowns, ceramic crowns. But I have solutions for all those things now. Okay? So we put brackets on and scanned. No, I'm sorry, we did indirect bonding through SureSmile, and we put the brackets on. And you can do this without SureSmile. You just have to bend the wire passively into there. We ordered a wire that was passive and put it in. So it started in June of 17, right? We put in her first SureSmile wire in July. She had the surgery done. Massive change. We're putting in a 1925 beta in 4 months. That's her finishing wire, and I'll make bends if I have to. But I know, you notice there's some brackets popping off here and there. I'm not worried, because at the end I can take an intraoral scan and I can do clear aligners to finish. How many times have you gotten to the end of treatment, you had 23 and a half months, and the kid expects to get them off at 24, and you got one little rotation? You can fix that now if you use clear aligners. Okay, in-house clear aligners. She had a problem with her smile. On this one, that was the time before, her frenum here and her frenum here were too tight. So I went in with the laser and released them. That's why she has a funky looking smile. So the decision you're making is, are you going to just straighten teeth? Or are you going to look behind the scenes? Are you going to look at the bite? Are you going to look at the airway? Are you going to look at all these other things? And if you are, and you know you can move jaws, you know we can have such a huge difference for these people that have sleep apnea. It's an incredible, and you get the way better hugs and thank yous for that when you say, they come to you and say, thank you for giving me my life back. It's incredible. More comprehensive diagnosis, better, faster results, and more comprehensive treatment. This is the sleep course. The next one's in October. I probably will do, it's not in the East Coast, it's actually in Atlanta. I'm trying to work out to do a laser course. If anybody's interested in either of those, or maybe an in-office sleep course, again, we did one in December, it was quite fun. Please let me know or let the HSO people know, and we'll get that arranged. Thank you so much for your attention.